Okay, so this section covers alterations in cognitive systems, cerebral hemodynamics, and motor function. Really what that comes down to is this really is a focus on what's happening in the brain. So we're going to talk about things like consciousness, Alzheimer's disease, amyotrophic sclerosis, things like that, hydrocephaly, and intracranial pressure. Okay, so to start with, we're going to start with consciousness, which is kind of a major alteration in a cognitive system. And consciousness, not to get kind of out there, but consciousness is just a state of awareness. Consciousness is what consciousness is. It's being aware of yourself, and it's being aware of the environment. There are a couple of aspects to it, mainly arousal. And that's your state of wakefulness with altered levels of awakeness, of awareness. So you can still be conscious, but you may not be fully conscious. So you may not be aware of everything around you. And for that, we have a different term, which is awareness, which encompasses all cognitive functions. So complete awareness would mean that you're aware of your environment, you're aware of yourself, and you have more clear thoughts. So let's look at some of the alterations in arousal. First of all, what can cause differences in arousal? So a lot of that can be structural, so something that happens within the brain, and those are, there are different ways of categorizing it, but this is categorizing it based on whether it's above the tentorial membrane, which is what we see here. This is the tentorial. This can be called the tentorial membrane, this little membrane here, and above that is really mostly the cortex. So we call that supratentorial, so something that happens up there, subdural bleed, which is something we'll talk about, and trauma, tumors that happen in this area. And then there's infratentorial bleed, which means, or infratentorial, I guess that's the location, and that really kind of encompasses the brainstem area, and one of the main functions within the brainstem is something called the reticular activating system. So damage to the reticular, or reduction in the function of the reticular activating system, or damage to the brainstem can cause an altered state of consciousness or unconsciousness. And then there are psychogenic, and those are usually psychiatric disorders. So somebody is unconscious, or their arousal is limited for reasons that can't be explained physiologically. And then metabolic, if you don't have nutrients, if you don't have enough glucose, for example, or some other electrolytes, then that can cause less clear thinking, I guess would be a good way to kind of picture that. So back to this reticular activating system, it's kind of an important region. It sits right down here in the brain, and it's really, or in the brain stem, and it's really a bunch of different little regions, and it kind of spreads all throughout this area. But the important thing is that it sits right in the path of both sensory and motor neurons that are entering and exiting the brain. So if we think about consciousness as being aware of our environment outside, and having control over that, being able to move, then this area, when it's down, or when it's not functioning, is really kind of important for that. So you can kind of see how it would have a role in consciousness. So shown to have a role in consciousness, coma, so lower activation during a coma. General anesthesia. So general anesthesia affects this. Now I want to say that general anesthesia also affects the cerebrum, so the rest of the brain, but it definitely will shut down this area, which doesn't allow movement and doesn't allow sensation. So loss of movement in REM sleep, and really sleep in general, and it really depends on the region, but it can shut down movement. Certain regions of it can shut down movement during REM sleep, and helps with selective attention. And some people have said that alterations in this function could have something to do with like attention deficit disorders. Okay, but that's not the primary way that we treat attention deficit disorder. So that's just kind of an idea, because it does have an effect it can have an effect on attention. Okay, so some other things that can have an effect is hypoxia versus ischemia, and just kind of a reminder, probably you know this by now, but hypoxia is low oxygen, but blood flow is preserved. So hypoxia is really just referring to the oxygen, so low oxygen. Ischemia, on the other hand, is low oxygen due to blood flow. Okay, so due to reduced blood flow. And so that's the main difference, is that ischemia really is talking about blood flow. Blood isn't able to get to the area, it isn't able to bring oxygen, and so it leads to hypoxia. Okay, so but whereas ischemia is really restricted to blood flow, hypoxia can be, low atmospheric pressure, carbon monoxide, anemia, so your blood can't carry even though there's blood flow, it's not carrying the oxygen the way it's supposed to. And so some of the, I guess, alterations in arousal that we would see with that are things like euphoria, listlessness, drowsiness, impaired problem solving, and you can see where that's sort of a reduction in consciousness, you could say, even though the person is awake. Okay, so if sudden onset, then unconsciousness and convulsions can happen. Okay, so ischemia, and so we're gonna kind of get into this when we talk more about strokes and ischemic attacks, but usually that's going to be something that blocks blood flow. Okay, all right. So other alterations in arousal manifestations, level of consciousness changes, pattern of breathing may change. Now, these are important because you're going to be thinking about assessment and how to assess levels of consciousness. And there are a couple of things. Post-hyperventilation apnea. Apnea means that a loss of breathing. And so this is varied breathing associated with carbon dioxide levels. So remember, your breathing rate really kind of depends on your CO2 levels. If you stop breathing, your CO2 levels rise. If your CO2 levels are low, then you're going to hyperventilate. So you hyperventilate when your CO2 levels are low, you hyperventilate when your CO2 levels are low, and then your CO2 levels become high, and that slows your breathing. And so you kind of go through this pattern where your brain is really just having a hard time keeping a normal CO2 level. Okay, and then the Cheyne-Stokes respirations, that's a pattern of breathing that starts slow, and then it speeds up, and then it slows again. So these are similar, but they're very different. This one is kind of a more rhythmic kind of change that happens, a more continuous rhythmic change, and it's just speeding up and slowing. You're not sort of stopping your breathing, which is what apnea implies. Some other things that can kind of be used to monitor levels of consciousness or arousal: pupillary reaction, so looking at the size and the response of the pupil; ocular motor responses, so that's movement of the eye; motor responses in general; vomiting, yawning, and hiccups. Now those are associated with the brainstem, and so like the vomiting reflex, yawning well, we're not really entirely sure what happens with yawning, but it is controlled by the brainstem, and then hiccups as well. And so that kind of indicates that there's some kind of either limitation or something is messing with brainstem function. And so you might see that. And here's some examples of pupillary reactions to localized injury. And you don't have to kind of go through all of these and know all of these, but it kind of gives you an indication in general. Now this would be just a preliminary assessment. You would want to actually see what the damage is using some kind of brain scanning. But you can see that diencephalic dysfunction, small and reactive, that's an example here. And so these are kind of pinpoint pupils. You can see where one pupil is constricted and one pupil is dilated, and that kind of may give an indication to dysfunction of the third cranial nerve. Here you can see metabolic imbalance. I think I said that because I have an arrow pointing to it. And midbrain dysfunction, mid-position, and fixed. So you can kind of see where you can get an idea of the brain damage or inhibition of brain activity just based on that. Okay, so other alterations in awareness. So now we were talking about arousal and how awake someone was, but we want awareness of ourselves and our environment. And so selective attention, inability or the ability to select from available competing environmental and internal stimuli. So I think we kind of know what attention means. It means that we're able to decide what we're going to pay attention to and sort of tune out the rest. And if that's inhibited, that could be considered an alteration in awareness. Sensory inattentiveness, so that means that your brain, for whatever reason, like if your parietal lobe is damaged, you get something called neglect syndrome, which is where if you were to draw something like a flower, then you would just kind of completely ignore one side of it. And because that side doesn't matter to you. And if you walk down the street, nothing, let's say on your left side, you won't even be aware of anything going on over there, but you'll be aware of stuff that's going on. And it's not from a vision problem, it's from an attention problem. It's from damage or inhibition of that brain region. Okay, and then selective attention deficit. You're not able to pick out and choose what you want to pay attention to. It all just kind of rushes in. And then memory amnesia can be a problem. So retrograde, retro meaning like the 1970s, but it's the past. It's recognizing something that's from the past. So you can't remember past events if you have retrograde amnesia. Anterograde is the inability to form new memories. So these would be like the 10-second Tom. You talk to them, you introduce yourself to them, you come back, 10 minutes later, and they don't remember meeting you. They're not able to process and put new memories in, even though they may be able to remember past events, okay, before usually some kind of a trauma, or it could be like alcoholism can lead to this. And then image processing, forming concepts, meaning, and general reasoning. So this is more higher level functioning that's going to require you to bring a whole bunch of past concepts together. And then executive attention is more of a planning kind of a thing to tune out a lot of different stimuli to keep a focus on a plan. Okay, so executive function usually refers to our ability to plan ahead. Okay, so so what happens when your brain is damaged to such a point that, or some other disease could cause this too, but either way your brain is not functioning the way that it's supposed to. So we have a couple of terms. Brain death. We hear about people being brain dead. And somebody that's in a coma is not brain dead, unless, well, really, I'm gonna skip down to the important thing here. Oh, well, I guess it's right here. Can no longer maintain internal homeostasis. So what does that mean? That means your brain is really there to, or one of the functions that it has is to regulate things like breathing and blood pressure and just sort of send signals, your thermoregulatory. So to keep your body temperature, the hypothalamus does a lot of that. And when it can no longer do that, then the person cannot survive without being, for instance, on a respirator. Their brain is not able to even perform those functions. And so really it's cerebral damage or lack of function of the cerebrum, as well as a lack of function of the brain stem. And so that's really where we get into something that we would refer to as brain death. Okay, so the person may still have reflexes, but because that's going to be spinal, but their brain is not able to kind of have this any kind of function that's even going to keep them alive if they're removed from a respirator. And so there are criteria, and these criteria can be are followed. And of course we know that there's some controversy about brain death and what can happen after brain death. But the idea is that if you follow certain criteria, that the likelihood of recovering from that is just astronomically low. So completion of all appropriate diagnostics, so you put them through the diagnostic and therapeutic procedures. They're not responsive, no motor and absence of motor and reflex responses that would involve the brain. Like I said, there are going to be some spinal reflexes. No spontaneous respirations. They don't breathe on their own. Pupils fixed, dilated, no reflexes. No pupillary reflexes. So these are going to be related to cranial nerves. Flat EEG, so they're not showing the normal any kind of normal, even sleep patterns of EEG, no ocular responses, isoelectric EEG, so it's not showing any thought patterns. Okay, so when there is a thought or when the brain performs something in a certain area, it's going to have a change that doesn't occur, and then it persists from 6 to 12 hours after onset. So a lot of times, that's when someone is declared brain dead. Now, we know that people slip into a coma, and that would be more of a cerebral death, because, and the really big difference here is that this person would be able to maintain some form of internal homeostasis because their brain stem is still functioning. So we make that distinction. We call it cerebral death. So the brain stem is still functioning, but essentially they are in a vegetative state. Okay, so death of the cerebral hemisphere is exclusive of the brainstem and cerebellum. No behavioral or environmental responses. Brain can continue to maintain internal homeostasis, and that's really the big difference there. Survivors of cerebral death, so people who are in cerebral death, the cerebrum isn't functioning, remain in a coma, emerge into a persistent vegetative state, progress into a minimally conscious state. So you may see their eyes open, but there's really nothing there, I think, is the idea. Locked-in syndrome is a little bit different. Locked-in syndrome, they're able to move their eyes, and they do seem to have some kind of awareness, but they're not able to function. Okay, so causes of this, you can probably kind of figure that out on your own. Direct destruction caused by ischemia, compression, so a tumor or some kind of increase in ICP, intracerebral pressure, cranial pressure, intracranial pressure. Effects of toxins, chemicals, metabolic disorders, anything that's going to kind of mess with the function of the brain. Now, let's move on to dementia. Dementia is usually associated with old age, although it doesn't have to be, because really the definition of dementia is a progressive failure of many cerebral functions, including impairment of intellectual processes. We kind of have an idea of when someone is demented or what dementia is, and that's, that's accurate. Losses of orientation, don't know where you are. Memory, language, judgment, decision-making, which I would call these similar. Maybe there's a definition I'm not aware of that makes them different. Well, actually, judgment would be, you're not necessarily making a decision, you're just judging something. But mechanisms include neuron degeneration, yeah, so direct neuronal damage, brain tissue compression, atherosclerosis, so that would probably involve blood flow, and then brain trauma. So that could apparently, especially if it progresses, and can be genetically predisposed. And we'll kind of talk about that because there are certain dementias that are genetic. Alzheimer's disease. Okay, so one of those that can be genetic is Alzheimer's disease, and it's genetic for a small subset of people, and in some people it will occur in the 40s and 50s, which would be considered young for developing dementia. And so we know that that's a genetic cause. Non-hereditary would be, really, I typically hear this referred to as late onset Alzheimer's disease, but it's not hereditary, at least not directly. So there are some ideas about what could cause it. There are actually a number of genes. Here are a couple of them that have been proposed. Mutation for encoding amyloid precursor protein, and we'll see in a minute that there's something called beta amyloid precursor protein that builds up and forms these plaques inside the brain, and we know that they're there, and so if we just look at that protein, some kind of a mutation in the production of that protein could lead to an increased formation of these plaques. There's another thing that's just been shown to correlate with late onset Alzheimer's disease, and that is an alteration in something called apolipoprotein E. which is a lipoprotein, which is kind of interesting, and maybe some kind of a relation um, to like eating saturated fats and cholesterol levels, and how that's dealt with that causes that increase in the amyloid protein. So Alzheimer's disease in general, most common degenerative disease, and progressive loss of brain function, memory loss, confusion, dementia, mainly affects people over the age of 50. Okay, and really the late onset would be over the age of like 65. Some say 60. But usually you don't see this until, you know, mid 70s, 80, 85. At around after 85, about 50% of the people are really at risk of having Alzheimer's disease. So it's responsible for 70% of all dementias, may be caused by chronic inflammation or oxidative cellular damage. But the thing is that we don't know why the brain is susceptible in some people and not as susceptible in others. And that's the same is true for these genes that I already mentioned, but here they are again. The apolipoprotein E4, which is associated with, like I said, cholesterol transport, and that's correlated with it. But there are a lot of people out there that live to be, you know, 90, 95, 100 years old, don't get Alzheimer's disease, but have this gene. So we just see sort of an uptick. So also maybe a mutation for encoding the amyloid precursor protein, which I already mentioned. So possible causes: genetic, said about 10% of the cases, chronic inflammation, and really that can come down to excess free radicals. So that comes down to, again, tissue damage and this amyloid protein that seems to build up with tissue damage. There are environmental factors, you know, toxins, certain pesticides, immunologic factors. That's complicated, but there are certain anti-pathogenic enzymes that we make that are very similar to the amyloid protein, and nutritional factors, viruses, any of these things may be a cause. And I probably should have put this earlier, but here's a picture of these amyloid plaques that I've been talking about. They're the ones here in purple. And those, not that this is, you know, like an actual picture, it's just a drawing, but you can see that these kind of build up all through the brain. And they have this core of this amyloid beta protein, and it appears to be a waste protein that's not properly cleared. So this is kind of produced all the time in your brain by everyone, but usually it's cleared out as quickly as it's produced, and so so it usually doesn't become a problem. Now there's something else that's also a criterion for Alzheimer's disease, and that's something called neurofibrillary tangles. So we have beta amyloid, it's actually called beta amyloid precursor protein, and or BAPP, and I didn't write that the way you're supposed to, and then tau. Tau is another protein. Tau is a protein that's really used to form microtubules, and you can see these tangles that happen. Okay, so you can kind of see them drawn in here, and these tangles are actually just out of control growth of microtubules, which are just a fiber that's found inside cells. Okay, so the way I remember this is there are Baptists, people who kind of believe that the beta amyloid protein is causing it, and there are people that believe the tau protein is causing Alzheimer's disease. So those are considered Taoists, and actually that's how I remember this: Baptists and Taoists. Okay, as long as you remember amyloid plaques as BAP, and neurofibrillary tangles are the tau. So changes only found during autopsy. So really you can't do a positive absolute diagnosis of Alzheimer's disease without actually looking at the brain and seeing these structures. Okay, so structural changes cause a loss in the number and function of the CNS neurons, beginning with acetylcholine neurons. Now this is important too, that you know that it's acetylcholine neurons that are affected first, and because the only treatment we have right now, well actually there are a couple that kind of alleviate or maybe treat symptoms, but the only one that really, so far, there are others being studied and actually administered that may also increase function, but is one that blocks something called acetylcholinesterase and causes an increase in acetylcholine. Okay, and that's been shown to increase function slightly, maybe at the early to mid stages. At the later stages, there's really not much treatment right now. So symptoms result from progressive damage to neurons in the hippocampus. Now, what you should know about the hippocampus is that that's where you form memories, and that's also where how you access memory. So the memories are really stored in the cortex, but they have to go through this region called the hippocampus to access these memories. So that's kind of where it starts. So we like to say that the hippocampus is the brain region responsible for learning and memory. Okay, and that's true. Without your hippocampus, you wouldn't be able to learn, you wouldn't be able to form new memories, you wouldn't be able to access memories, and that's what happens with Alzheimer's disease. Is the memory is the first thing to go, and then acetylcholine is one of the neurotransmitters in there. Now, the thing is that Alzheimer's progresses, and you can kind of see the difference in brain tissue here. You can kind of see that the sulci or the wrinkles get a little bit larger, farther apart. It just looks a little, it becomes smaller, and then it starts to affect other areas. So you can see language is here. So as it progresses, it just gets worse and worse. So it begins in the hippocampus, but it moves on to affect the whole brain. Ultimately interrupting the ability to swallow, the ability to breathe, those kinds of things. Okay, I just wanted to point out one other type of dementia. This is it's familial association. So it has an actual gene mutation, and it's a gene mutation in this protein called tau. Okay, so this microtubule protein. And it's rare, but it's severe, and it's degenerative. Okay. So it's called Pick disease also, but frontotemporal dementia, probably based on where it shows its original damage. Death of frontal lobe and lobe tissue and dementia, familial association. Yeah, most cases involve a gene mutation in this tau protein. Okay, so that's dementias. So now we'll move on to seizures. And a seizure is really just what causes a seizure is just neurons firing everywhere out of control. So that's one way of saying it, or the fancy way, an abrupt transient occurrence of signs and symptoms resulting from an abnormal excessive discharge from an aggregate of neurons in the brain. So yeah, it's a whole lot of neurons firing without any kind of coordination, and they kind of cause other neurons to fire, and it just kind of moves out of control. Okay, and there are a lot of ways that seizures can occur that we'll talk about. Usually, it's a manifestation of a disease. Okay, so something, and there are a number of different diseases that we'll see that have seizures as a side effect. Okay, like eclampsia or something like that. Spontaneous nerve firing, that's what it is. Provoked, so there's a difference here. So provoked seizures, and this is important, provoked seizures would be considered secondary. Okay, so that means that something is causing it. So there's some kind of other pathology that's causing it, that if you stop that other pathology, then you can stop the seizures. Okay, so febrile seizures are caused from a fever. So when the fever isn't there, then the seizures wouldn't take place. And this is something that happens in young children. Electrolyte imbalances can cause it, which makes sense because neurons are very sensitive to the ions that are around them in the right concentrations. Alkalosis, so pH. Hypoglycemia, so a loss of sugar, and insulin, high levels of insulin can cause seizing too. CNS infection, damage, so yeah, just about anything that's going to affect brain function can lead to seizures, within reason. Now, the other thing is unprovoked seizures. Now, unprovoked seizures mean that the seizures are the problem. Okay, so we don't see any other pathology associated with it, at least not that we're aware of, and so we consider the seizures being the problem, and this is what we refer to as epilepsy. Okay, so epilepsy is kind of a disease on its own, and it's a disease where you have regular, recurring, unprovoked seizures. Okay, so that's what epilepsy is. So let's talk about the different kinds of seizures. There are partial seizures, and partial refers to how much of the brain is affected. Okay, so a focal means a certain area, so that means a certain area of the brain is affected. Initially only affect one hemisphere of the brain. so that can be broken down. So a focal partial seizure would be only one hemisphere of the brain. A simple seizure means usually that the patient retains awareness during the seizure. A complex seizure would be that the patient loses awareness. So partial seizure. So we have simple partial, complex partial. Okay, and these are some of the symptoms. That's not where I want to trip you up. I kind of want you just to know the big differences between these. Okay. Generalized seizures. Classifications. Let's see. Where am I? So generalized seizures. These would affect the whole brain. Okay, or at least a large part of the brain. I don't know that we can go in and say, oh, there was, a couple of neurons there that didn't fire, but it's the whole brain or a large part of the brain. Either way, it's going to get both hemispheres involved. So there's something called an absence seizure or absence seizure, and that is a brief loss and return to consciousness. So a lot of times these people don't even know that they had a seizure. They just sort of pause for a little while. This can happen in children. They pause for a little while and they're just kind of out of it, and then they just keep going as though nothing happened. Maybe it only lasts, just a little while, like under a minute. Okay. So that's an absence seizure. So they aren't actually doing what we think of as seizing. They aren't having convulsions. They just sort of stop functioning. Atonic seizures, which are sometimes called drop seizures. Now, tonic means muscle tone. That's a state of contraction of the muscles. That's what tone is. Muscle tone is having some kind of activity in the muscles, which is causing a partial contraction. We have muscle tone all the time because our muscles are always somewhat contracted. Well, atonic means that stops. So that's a brief loss of muscle tone caused by alterations in brain function. So something happened in the brain that caused this loss of tone. Okay, so that's a drop seizure, an atonic. And then there's tonic clonic. Now, if you think about what tonic means in tone, and that's a partial contraction, well, a tonic refers to when you seize, your reflex or your muscle tone increases to the point that your muscles just tighten. Okay, and that's tonic. And then clonic refers to, for lack of a better word, it refers to convulsions. Okay, so a tonic clonic seizure would involve, so it would involve a loss of consciousness and then tensing of the skeletal muscle, which is tonic, followed by violent convulsions, which is clonic. Okay, so somebody who's having the seizure would seize up. Okay, not to use the word in the definition, but would seize up, and then they would start convulsing. So if we go through these: absence, I say absence, I know absence, but absence is easier. So lasting a few seconds, seen most often in children. The child stares into space, does not respond to verbal stimulation, may have fluttering eyelids or jerking, and so that's usually going to be noticed by someone else that's paying attention. Sometimes misdiagnosed as ADD, attention deficit hyperactivity disorder, or daydreaming, something like that. So, it's something to kind of be aware of. Atonic, falling or stumbling for no reason, also lasts just a few seconds. And then the tonic-clonic. The tonic-clonic are a little more serious, or a lot more serious. Well, I guess any of these can be serious. It depends on what results from it. But they usually have an aura, and then intense muscle contraction, which is the tonic phase, followed by the clonic phase, which is alternating contraction and relaxation of muscles. I think that's the moving back and forth type of behavior. So I have this here: crying at the beginning as air leaves the lungs. So that could just be a loss of control of the musculature of your pharynx or something like that. Loss of bowel, bladder control, shallow breathing with periods of apnea, which is not breathing at all, usually lasting 1 to 2 minutes. And then the post-ictal is the term we use for that. The post-ictal state would be disorientation. So if there are Okay, so we'll come back and refer to those stages. But there are some other special seizures, and we've already mentioned some of them, one of them at least, febrile. So febrile is a special type of seizure. It doesn't fall into the partial or generalized. And so that's associated with a rapid temperature increase. So we could say, I mean, we would like to say, and it makes sense to say, that a rapid temperature increase, a rapid fever in a child from 3 months to 5 years can cause or lead to a seizure or some kind of seizure activity. Okay, so that's a febrile seizure. If they didn't have a fever, then it wouldn't be considered a febrile seizure, right? So myoclonic, so this is missing the tonic part of this. It's muscle. Myo is referring in this case to muscle. So large jerking movements, but it doesn't have the rigidity that you would have with the tonic-clonic. And then this one, I have it here in purple, which almost makes it harder to see. I'm trying to highlight it, but status epilepticus, that's the one where someone will not stop seizing and they continue to seize, and that's a medical emergency. They have to be treated with some kind of, usually some kind of a GABA agonist, some kind of an inhibitory drug that activates these inhibitory neurotransmitters to kind of calm everything down. And people with epilepsy also take these inhibitory drugs, something that activates GABA, which releases chloride and is inhibitory, and so to sort of prevent this increased activity. Okay, so seizure stages, this is just kind of a quick run through. Prodromal phase, which is this aura, and sometimes you can tell before the aura even starts. You can kind of start noticing a difference in behavior, but an aura indicating a seizure is imminent. And those have been described as different ways, seeing colors, lines, something like that. Something that's recognizable as my brain is not really functioning the way it's supposed to. And then there's the tonic phase, that contraction, and then the clonic. So in this case, we're talking about a tonic-clonic fever or seizure. And tonic-clonic are usually the ones associated with an aura. And then there's a post-ictal phase, period between immediately following the seizure, and those are behavioral changes that may last for hours and I guess even days. Okay, so you can recognize these behavioral differences for quite a while after the seizure is over. Okay, so that's seizures. Now we're going to move to intracranial pressure. So this is pressure that is in your cranium. Makes sense. So let's look at the source of this, because if we look at the source of your intracranial pressure, or, I mean, you have to have some kind of pressure, then it comes from several different things. First of all, you have stuff in your brain, like neurons, and you also have blood that's found in blood vessels. It's not just, oozing through your brain, but it's found in blood vessels. And then cerebral spinal fluid, which is found in your ventricle system. And then about 80% is brain tissue with the fluid in and out around that brain, the neurons that are in your brain. So how would we, increasing the volume of any of these things, so increasing blood volume, so vasodilation, venous outflow obstruction, something that's not letting the blood flow through just the way that it's supposed to. If you have vasodilation, that's going to increase blood flow to the brain, which is going to increase that 10% a little bit, which is going to increase intracranial pressure. CSF volume, so if you produce too much CSF, cerebral spinal fluid, which is what's kind of going around the ventricles, but if you make too much of that, or if you obstruct the circulation somehow, it could cause an increase in certain areas, or if it's not able to leave. Okay, so we'll look at that with hydrocephaly. So tissue volume, like a tumor, that makes sense. A tumor or fluid collecting in the brain. Yeah, I'm talking about it could be intracellular or interstitial. Bleeding, blood moving from the vascular into the tissue, it would also increase pressure. Okay, so hopefully these kind of make sense. So we have something called cerebral perfusion pressure, and that's the pressure required in the brain to maintain perfusion of brain tissue. So that key word right here is perfusion. I kind of try to really bring that word out because that word, when we're talking about physiology, means the ability to provide cells with nutrients. Okay, so it's the ability for fluid to kind of flow around your cells, which it always has to bring it, you know, glucose, oxygen, ions, all that stuff, and remove the waste like carbon dioxide. Okay, so that's perfusion. You want your cells to be perfused at all time. You want that fluid to be moving around them all the time. So that's the pressure required to, so perfusion pressure is the amount of pressure to do that. Okay, so usually, so cerebral perfusion pressure is the mean arterial pressure, which mean arterial pressure is kind of between systolic and diastolic, but a little lower than halfway, because you spend more time in diastolic. But that's mean arterial pressure, so it's kind of an average. And then you take that and you subtract the intracranial pressure, and that's going to be your perfusion pressure. So you can see that if your arterial blood pressure drops or your intracranial pressure increases, your cerebral perfusion pressure is going to go down. Okay, so I can say that again. If you decrease your blood pressure, so the blood pressure going to your brain decreases, well, that kind of makes sense. You're not going to have that perfusion the way that you should. Or if your blood pressure is fine, but the pressure within the brain, your intracranial pressure, increases, it's going to also inhibit that flow into the brain, and you're not going to have the perfusion that you need. Okay, so that's kind of what that is. So you end up, so there's something called compartment syndrome in the skull, and if you can imagine the intracranial pressure becoming so much that it kind of overwhelms the blood flow coming into it, then those arteries collapse. They can't move the blood in, and your blood flow to the brain is completely cut off. Okay, so obviously that's going to lead to death. So first of all, we'll talk about well, pretty much all we're going to talk about is increased intracranial pressure, because that's really where we're talking about the brain, and that's a big problem. So caused by an increase in intracranial content, we've already mentioned things like tumor growth, edema, too much CSF, hemorrhage, so some kind of damage that's releasing blood. So first of all, let's talk about cerebral edema. Okay, so edema is fluid collecting outside the vasculature, so outside the blood vessels. That's really what edema is. So there's something called vasogenic, and that means that, so usually your blood-brain barrier, which really kind of directed by these glial cells called astrocytes, but usually the blood-brain barrier is kind of selective about what's moving in. And so water is able to move in, and usually that's okay, because it's working the way it's supposed to be working. So water and proteins from the vascular, if it's causing edema, that's impaired. Okay, so the ability to kind of control that fluid movement into the brain is impaired for whatever reason. And water and proteins from the vascular will move into the interstitial space, especially if you have more particles moving in, so some kind of a leakiness, particles moving in, water's going to move in, and you're going to increase fluid in the brain, that interstitial fluid. Okay, so that's vasogenic. It came from the blood-brain barrier, so it's really from the blood. It doesn't have to be hemorrhage, but it can be hemorrhage, so that means blood cells are moving in too. So hemorrhage, brain injury, infections can cause this. And just kind of a little side note here, it tends to affect white matter tracts more than gray matters. I don't know why. I'm sure there is a reason. I just don't know it. But that's just kind of something. Responsible for herniation if severe. So herniation means that some kind of tissue or something has pushed into an area where it shouldn't be. Now there are a lot of nooks and crannies. I don't really want to say that, but we looked at the tentorium before, and so if the brain pushes past something like that, then it will be pushed around to places that it shouldn't go. I guess is without having a picture here to draw of it. That's kind of what happens. It'll squeeze past certain connective tissue structures in the brain. Okay, so that's the herniation that it can happen in the brain. It's not like squeezing out of your ears, although I suppose that's possible in a weird way. So manifestations, focal neurodeficits. So focal just means that it's in a certain area, specific locations. Altered consciousness, which we learned a little bit about, and intracranial hypertension. So that's higher blood pressure. So that's vasogenic. There's another one called cytotoxic. Okay, so cytotoxic really doesn't, we're not really thinking about the blood or the contribution of blood vasculature. We're thinking about what's actually happening to the cells. Okay, so this is swelling of brain cells due to hypoosmotic states, which hypoosmotic means that here's your cell, okay, with its normal number of particles in it or concentration in it, and what happens is that fluid can build up out here, and that's going to cause fluid to move into that cell, and it will swell. Okay, so it'll get larger. So it's really cell swelling. So swelling of the brain cells due to hypoosmotic states. So water intoxication can do that. Severe ischemia can lead to that. Dysfunction of the sodium-potassium pump is a big one. Okay, so if you can't get oxygen, so if you are ischemic and you are unable to get oxygen, your sodium-potassium pump will slow down or stop functioning, and then you're going to have a buildup of sodium inside. So it's supposed to be kicking sodium out, more sodium than it brings in potassium. It's supposed to be kicking sodium out. Sodium builds up inside. It's going to cause water to move into that cell. Okay, so it can lead to cerebral infarction. Infarction just means tissue damage with necrosis of brain tissue. So major changes in cerebral function, stupor, and coma can come from that. Okay, so here's hydrocephalus. Hydrocephalus, the hydro in this case, in most cases, refers to water, and the cephalus refers to brain, so it's brain, water in the brain is kind of what that's trying to describe. But really, this is what you need to remember. It's excessive fluid within the cerebral ventricles. Okay, so this is not necessarily, this is not interstitial, this is not your blood vessels, these are the ventricles. This is your cerebral spinal fluid. Okay, that's building up. So excessive within the cerebral ventricles, subarachnoid space, or both, because they kind of are all part of that flow. So caused by interference in cerebral spinal flow, decreased reabsorption, increased fluid production. Both of these make sense. Reabsorption means that it's being reabsorbed and then sent back through the sinuses or the veins that are leaving the brain. So it just doesn't leave and it stays in there and builds up. Obstruction within the ventricle system, which can cause well, it can cause something like this, where it builds up in one area, but not necessarily all areas, and it kind of pushes the brain out of whack. Okay, so let's go through these. So hydrocephalus, abnormal increase in CSF volume with progressive enlargement of the ventricular system. Now I will say that you can see in this baby, and this is really it's, I don't want to say it's common in babies, but it's more common in babies than it is after that, infants, and or even pre. And what you can see here is the fontanelles, the bones that sort of enclose the brain. The cranial bones haven't formed yet, and so the head is still very malleable and can move. And so as this fluid builds up in the ventricular system, then it will push out on the brain, and the brain will become very large. Okay, and it's really fluid that's causing it to be large. This baby isn't a genius, but it's fluid that's causing it to be large. Now, if these fontanelles haven't fused, then the brain can become large, and it really doesn't cause damage to the brain, or it shouldn't. Now, it's when these fontanelles, these sutures have formed, and they're rigid, and the cranium can't expand, the skull can't expand to accept this extra fluid, that's when brain damage can occur. So seeing a baby like this with the enlarged skull, is actually not such, I mean, it's bad because you don't want it to happen, but it's not as bad as when those have fused. At least the brain can take on that extra fluid, and once you get rid of that fluid with a shunt to drain that fluid, then that it can actually go back to normal as long as you've eliminated the cause. Okay, so abnormal increases in volume, progressive enlargement of ventricular system often occurs in infants prior to birth. Okay, so that's what I was kind of saying. I was calling that an infant, but it could be a fetus or about to be born. So treat with the shunt to drain the fluid from the ventricles or the CSF, cerebral spinal fluid compartments. Now, there are two types. And I like, it's communicating and non-communicating. I would prefer non-obstructive and obstructive because those are a little bit more descriptive. So non-obstructive means that, so normally as fluid moves around and through the ventricles, it goes through this arachnoid space here. Okay? And then it's reabsorbed back into the sagittal sinus. And that's it's venous blood flow. Okay, so it's reabsorbed back into the blood, and then it's drained from the brain. Okay, so it's drained from the brain. So that's what's supposed to happen. Is this is supposed to kind of be produced. The cerebral spinal fluid is made, and then it circulates around, and then it leaves through these sinuses, and there are little alveoli sticking up in there so the fluid can kind of move out easily. But if that system gets clogged, and this should make complete sense, if that system gets clogged, then the fluid can't leave. Okay, so it just can't go away. And so it's stuck in the, and it backs up into the ventricles and into this subarachnoid space. Okay, so it's impaired reabsorption, it's communicating. Inadequate number of villi formed could cause it. Post-infective scarring, so meningitis can cause this. So this is why it would be more serious in someone older. This can occur in someone older. Obstruction of villi by blood or debris, so that could happen with some kind of an injury. So that's communicating. You just can't reabsorb it, and so it's stuck in there. Non-communicating or obstructive means, and this is congenital, okay, so this is the one that you're going to see more often in infants prior to birth. So it's obstructive, which means that there's some kind of lack of communication between the ventricles. Okay, so maybe from the third ventricle to the fourth ventricle you have the cerebral aqueduct, and maybe that cerebral aqueduct is narrowed. Okay, so we would call that, where is it, aqueduct stenosis. Stenosis means narrowing. So fluid's not able to move through, and so the fluid can back up. Okay, in this way. So in this case, the word communicating refers to the fact that there's some blockage within the ventricular system that's causing a lack of communication, I guess, from one ventricle to the next. Maybe a way to look at that. And so it's going to back up, and it's going to cause an increase in fluid and the swelling that you see. Okay, so congenital malformations is a big one. Tumors can also cause it. I mean, if you have a tumor pushing on a certain area that's causing it to block flow, that makes sense. Inflammation, yeah, it's kind of the same thing. Hemorrhage can also cause it. Anything that's going to block the communication of the ventricular system. So blocks flow of CSF within the ventricular system. Okay, so now we're going to talk about some movement disorders. So first of all, a couple of terms here. So hyperkinesia, it's excessive movement, hyper, excessive. Hypokinesia is going to be decreased movement. Okay, there are a couple of subterms that I have here. Paroxysmal dyskinesias, those would be abnormal involuntary movements that occur as spasms. So when we think of a spasm, that's a type of hyperkinesia. Tardive dyskinesia is something usually associated with taking drugs too long. And so we have here prolonged antipsychotic drugs. So somebody that they used to treat people with haloperidol, we still do treat people with haloperidol, but long-term, usually the typical antipsychotic use would can lead to this, like things like chlorpromazine, thorazine. Those can, long-term treatment with that can lead to this tardive dyskinesia. Tardive means delayed. It usually happens much later, but after a long time of this drug use. But it's involuntary movement of the face, lip, tongue, trunk, and extremities. So you'll see like lip smacking, stuff like that. The tongue can't be controlled. It's just kind of moving around. And also can be, the trunk and extremities may look like, very uncoordinated kind of movement. So antipsychotic drug therapy, it can also be caused by things like, long-term meth use, can also lead to tardive dyskinesia. Hypokinesia, so this is a decrease in movement, so akinesia. Bradykinesia, which is slow movement. Akinesia would be a lack of movement or an inability, and lack of associated movement, so things aren't really working together. Okay, so those would be considered a hypokinesia. All right, so I want to talk about a term here, because when we talk about these other neurological diseases, these terms kind of are important. Not really terms, but more areas, types of neurons. So upper and lower motor neurons. We have from our brain, from the motor cortex of our brain, we have neurons that are heading straight down to activate other neurons, which then go out and activate the muscle. Okay. So if we simplify it and we say, okay, we have neurons coming from the brain and then synapsing with these neurons, the spinal, which would ultimately become spinal nerves. They synapse with these spinal neurons, and so we call this one upper and this one lower. Okay. The reason this is important is because of the effects that they have. So if we have something like Parkinson's disease or something that affects upper motor neurons and doesn't let that signal get out at all, then you're going to see more of a flaccid type of effect. Okay, so well, actually that's not entirely true. Let's just go through it. Okay, so upper motor neurons, brain originating in the cerebral cortex. Lower motor neurons activate muscles. So they originate in the spinal cord. My word originate is blocked off there, but they originate in the spinal cord. That's where the lower motor neurons originate. So so upper motor neurons send their axons down through the internal capsule, which is just a brain region, and to the lower motor neurons. So the axons run down the white matter of the spinal cord and then exit through the spinal nerves to the peripheral nervous system, which is everything outside. Okay, so we have that handoff, and that's what we'll look at in this next slide. So so upper versus lower. And these diseases, some of the diseases we'll talk about affect upper and lower differently. So if it's upper, these upper motor neuron damage, and this is where I lied to you before, spinal reflexes will remain intact. And that makes sense because if you damage upper motor neurons, then so if here's your spinal cord and the nerve is leaving, you still have communication between the muscle and the spinal cord. So you're still going to have spinal reflexes. Your brain just isn't going to be able to control the movement. Okay? So hopefully that makes sense. If you have upper motor neuron damage, your spinal nerves are still fine. Okay? So there's no damage to the spinal nerves. So upper motor neuron, let's see, spinal reflexes remain intact, but cannot be modulated by the brain. So you're going to have actually increased muscle tone. Okay? Hyperreflexia, because it can't be, so you're going to have reflexes, they're just not going to be controlled by the brain. Same with spasticity and resistance to movement. Okay, so you're going to see that when there is, I guess, brain damage that affects motor neurons. Lower motor neuron damage, that means that the neuron that is leaving the spinal cord has been damaged or destroyed. There go your reflexes. Okay, so you can't have spinal reflexes if you don't have a spinal nerve coming out or the neurons that are responsible for it. Okay, so lower motor neuron damage, death of neurons, spinal reflexes are lost. That means you're going to have flaccid paralysis. There's no way you're going to be able to activate those muscles even from a reflex. There's just no innervation to it. Denervation, atrophy of the muscles, they're going to kind of waste away because they're not getting that feedback signal. Okay, and I have down here a note, amyolateral sclerosis, or ALS, Lou Gehrig's disease, usually involves upper and lower, but there's a spectrum of involvement, so it could be more upper, more lower. We're actually going to talk about that disease. So spinal cord injuries could also damage one or the other or both. Okay, so let's talk about Parkinson's. Parkinsonism is a syndrome of abnormal movement, and it's usually caused by Parkinson's disease. It involves tremor, rigidity, bradykinesia, so slowed movement, caused by the destruction. So in the case of Parkinson's disease, it's caused by the destruction of an area called the substantia nigra, which is part of a group of brain regions called the basal ganglia. And I have a picture of that here, which kind of gives you an idea. You don't have to know all of these regions, but here they are. And they have to communicate with each other, and they communicate with each other in a very coordinated way. When you initiate a movement and when you continue a movement, your basal ganglia is handing off signals to keep that movement coordinated and intentional and direct. Okay, so any kind of disruption in this can cause movement disorders. In the case of Parkinson's disease, what happens is this little area called the nucleus, well, actually, no, I'm pointing to the wrong thing here. This little region called the substantia nigra, sorry about that, substantia nigra is damaged, and the substantia nigra is this area, it's dopaminergic neurons. Let me really erase that because that was bad. So the substantia nigra is there are a lot of dopaminergic neurons, D1, D2, and that's going to be responsible for really initiating movement, but also some coordination of movement, the feedback loop that happens when you move. And so we're constantly losing neurons in the substantia nigra, and when about 80% of those neurons are lost, then we start showing symptoms of Parkinsonism. Okay. Okay, so that's the movement part of this due to the basal ganglia. But the basal ganglia can also influence the autonomic nervous system, and so you'll also see excessive sweating, sebaceous gland secretion, salivation, and later this damage doesn't just kind of stop there, but later develop orthostatic hypotension, which means that that's drop in blood pressure and a change of position, thermal regulation problems, so the hypothalamus, and incontinence, dysphagia, difficulty swallowing kind of thing, and that's a lot of times a diagnostic criteria. Do you have any trouble swallowing? And that can kind of show up there too. Okay, so like I said, they're primarily dopamine neurons, so drug therapy involves increasing dopamine, and you use L-DOPA since dopamine itself, which is a precursor to dopamine, since dopamine itself doesn't cross the blood-brain barrier. Okay, so manifestations, like I said, severe degeneration of the basal ganglia, mainly this dopaminergic nigrostriatal pathway, but you see the tremor, rigidity, bradykinesia, which I mentioned, postural disturbances, so you can kind of see a stooped posture. Mentioned the autonomic, so fight or flight, rest and digest, so sympathetic, parasympathetic, neuroendocrine symptoms, cognitive affect symptoms, and so all of these things can, as it progresses, it can get worse and worse. Okay, okay, so Huntington's disease, not going to say too much about that, also known as Huntington's chorea, and that is hereditary. Okay, it's something called a CAG repeat, and it's so it can be traced back to a particular gene, and so it's a dominant gene. So if you have it and you have that repeat, then you're going to develop Huntington's disease. It's severe degeneration of the basal ganglia, so our basal ganglia is involved, which is movement, but it really presents differently. You go to make a movement and you're not able to stop it, and so you'll go to raise your arm, and you, instead of raising it a couple of inches, you raise it all the way over your head, and that's what causes that chorea, which is a term for dance, and like choreography, and so it causes that dancing-like movement. But in this case, instead of Dopamine, it's GABA that's depleted, and GABA is inhibitory, which is what's responsible for some of that lack of inhibition in the chorea. Okay, so the last one, I think, is ALS, Lou Gehrig's disease. It's a neurodegenerative disorder involving both upper and lower motor neurons. Now you can see when your basal ganglia, before I didn't mention it, but your basal ganglia is damaged, that's going to be more upper motor neurons, so you're going to maintain those reflexes. ALS, progressive muscle weakness. We don't know what causes it, although there are some familial types that are genetic, and we do know what causes those, and it's usually oxidative damage. Starts with muscle weakness and progresses to muscle atrophy, spasticity, loss of manual dexterity, and gait. Okay, so it progresses in different ways for different people, and so that's just kind of the way it is, because it may affect more upper motor neurons, lower motor neurons. If it starts to affect the respiratory, the diaphragm, then that's usually what causes death. Okay, so ALS, amyotropic lateral sclerosis. I sometimes leave off my tropic. ALS, Lou Gehrig's disease, can damage both upper and lower, and it's progressive. Okay, so it tends to continue. It's not something that just goes a little ways and then stops. That's not normal. I don't know. Stephen Hawking is different. But upper motor neuron damage, we kind of already went over this, so I'm just going to go over it quickly. So if it's damage to the upper motor neurons, loss of motor nuclei, of the cerebral cortex and brainstem, weakness, lack of motor control, loss of control over spinal reflexes. They're still there with upper motor neuron damage. Don't forget that. Leading to stiffness and spasticity. If it's lower motor neuron damage, then you have loss of fibers in the anterior horn of the spinal cord. Okay, so you've lost, you're losing spinal neurons, and this is just telling you where. So irritation leads to fasciculation or twitching initially. Decreased neuron firing leads to weakness, denervation, atrophy, hyporeflexia. So that's where you have loss of reflex. Okay, and atrophy because you're no longer communicating with those muscles, and they will just denervation and atrophy. If you don't have communication with the muscles, then the muscles will just die. Okay, so they'll just kind of shrivel up. I don't know about die. They will eventually, but first they atrophy because there's nothing to stimulate them. Okay, so first they get smaller. So there are different types, but overall the cause is unknown. May be related to free radicals, so this is a familial form. It's a lack of production of superoxide dismutase, which is an antioxidant, and you can't produce it, and so these oxidants build up, and these free radicals build up and damage the cell, damage the neurons, and that's what's destroying them. So we know this one, but in most cases we don't know. Glutamate toxicity may overactivate neurons, causing neuronal death. Sometimes it's related to drugs. Toxins can it's very common actually for toxins to lead to that, and especially Parkinson's disease. Toxins can lead to that too. So death usually occurs to deterioration of diaphragm neurons. Okay, and that's it for this chapter section.